It's a pleasure to have you on board, sir.
No. It's all right. This is a thank goodness you gave me something which I already have prepared. Otherwise, I would have refused. It's just that
Topic has a lot of interest, and Dr. Madhusudhan happens to be a speaker for the same topic in the last NAPCON.
Okay.
Both we have
Great.
seasoned people, and you have been a very seasoned speaker and a very sort of teacher kind of phenomenon in this part, at least. I don't know on the other side. Madhu, go ahead.
Sorry, sir. Good evening, sir. Kola, sir. We are good to start, sir.
Yeah, Madhu.
Okay, please.
Madhu, please introduce Sir Ramsubban.
Okay. Good evening. Welcome to our webinar. Today's speaker, well-known speaker, Dr. Suresh Ramsubban, sir, who is an American board qualified critical care internal medicine and pulmonology, who is working as a senior consultant critical care at Apollo Hospital, Kolkata. Sir is having the vast experience in the critical care and pulmonology. And today's topic for discussion is their optimization of the driving pressure and PEEP. What are their implications and day-to-day practice? This is the topic is very common and very near to the heart of most of the people who are practicing critical care. A lot of controversies are there about the PEEP, high PEEP or low PEEP. And the one more concept is there about the driving pressure. Now, most of the people want to do something good, so that we listen from the best speaker of India at international level also regarding his thought processes about driving pressure and optimization PEEP. Over to you, sir.
Thank you very much. Thanks for the invite. And once again, as I said, it's a pleasure to be speaking on a topic which is, as I said, familiar. And thanks to Venkat and Dr. Madhusudhan for asking me to be here. I said this is a topic which we just spoke about recently in the South Zone Critical Care Conference. Is my slide clear? Slide visible?
Sir, it needs to be full screen, sir.
Is it full screen now?
Yeah.
Yeah. Alrighty. So the topic was basically driving pressure and PEEP optimization in ARDS, and we will talk about it. And the objective of my talk is going to be just give a brief about what is the goals of mechanical ventilation. Where are we as far as the role of PEEP in oxygenation is concerned? What's the concept of lung protective ventilation, and where does PEEP and driving pressure fit into lung protective ventilation, and where we are? And obviously there's no consensus as of yet, but there might be some data, that is the European EDICCM has come up with a consensus statement, and many other societies have come up with a consensus statement on certain things to be done, and we'll just briefly touch upon that. All right. So this is what is very, very difficult. Is first, let's discuss the definition, because definition always gets controversial. So when you see the guy on the left side who's come in with dyspnea, hypoxemia on 70% saturation on room air, he's not ARDS because he's got one-sided infiltrate, and he has acute kidney failure. So that time at point is he's acute pneumonia, acute with hypoxemic respiratory failure. But 24 hours down the line, he's got bilateral alveolar infiltrates, and he's got Berlin. He meets the Berlin criteria for ARDS because he's got bilateral alveolar infiltrate. So just hypoxemic respiratory failure and bilateral infiltrates is what does it make all the difference. Does he have renal failure, which is volume overload, which is leading? So there are a lot of issues that has happened in between in these 24 hours to this patient, which makes ARDS an interesting phenomena. As I said, it's initially described by Ashbaugh and Petty, and it's very interesting to know that this disease obviously existed before Ashbaugh and Petty described it. So it's not like this disease started to exist only after the definition in 1967. It used to be called a little differently. It used to be called wet lungs, or it used to be called congestive atelectasis. That's the term which, in fact, Ashbaugh and Petty used it to describe this in the seminal paper in Lancet. They called it adult respiratory distress syndrome because it kind of was slightly different from the infant respiratory distress syndrome. And so at this point in time, you have to understand that this definition itself, a wet lung, a congestive atelectasis, is what originated the concept. If this is atelectasis, maybe this is a time where we can use a PEEP. We can use certain things to get the collapsed lung better, and patient might get better. And that's what they said. So the seminal paper in 1967 actually said that PEEP as a therapy for ARDS, and that's what was described because they used PEEP to increase the mean airway pressure, and that created an opening up of the alveoli. And for a young trauma patient who was very difficult to ventilate, they were able to ventilate, and they were able to oxygenate this patient, and they could get the patient better, and they had a series of 13 patients. Obviously, this definition has undergone various changes over the years, from the 1971 first definition to the Murray definition of lung injury score, to the 1994 consensus statement, and to the present day Berlin definition, which, as I said, has to be within a week, which is what you saw in that X-ray. Within a day, you had bilateral infiltrates. And these bilateral opacities are not fully explained by effusions, lobar lung collapse, or nodules. And the origin of edema is not because of cardiac failure or fluid overload. As I said, in this patient, it may be renal failure. We don't know what's happening, but you need an objective assessment with the echocardiography and to assess whether hydrostatic edema is there or not. And if then you classify them into mild, moderate, and severe based on the PF ratio. So this is known to everything, and there is a few issues about how do you compare, but then there are certain problems with this Berlin definition, and one of the important, that's why we have the Kigali modification, where we're looking at not only looking at PF ratio, but to look at the SpO2 PF ratio. We are looking at HFNO criteria, because a lot of patients of ours are put on HFNO rather than on any invasive mechanical ventilation straight away. We are looking at, instead of chest X-ray, looking at CT chest and lung ultrasound to diagnose it, and whether unilateral opacity is to be allowed. As we said, the first X-ray itself gives 70% on room air, so maybe something. And what's the minimum time frame? We have seen this in COVID a lot, that the people who have come in for 7-10 days, and then it's only subsequently that the oxygenation gets worse and they require ventilation. Otherwise, they're holding on non-rebreather mask or oxygen for quite some time, even though they're holding on for more than 7 days. And more importantly, about 10% of ARDS gets better with Lasix. So maybe, or some diuretics or some other thing. So it is 10% of patients do not have ARDS in 24 hours. Should we wait for 24 hours before we call this as ARDS? These are the few issues that crop up when we talk about the definition of the ARDS and this thing. But as I said, the topic today is not to debate whether do we have a consensus on the definition of ARDS, or do we need to proceed any further. Yes, there is not significant, we still have a long way to go to define this entity, but this entity gives you a broad idea as to what's happening. So what's really happened is in ARDS is the pathology that's happening, and these are electron microscopic pictures of the tight junctions, which we never knew. And these are pictures. This is a review in Nature published by Mike Mathey, and it's an open access journal, so anyone, if you interested, can just review it, and you'll understand that there is a barrier. There are two tight junctions, which gets damaged in ARDS. One is the endothelial tight junction that is responsible for it, and the epithelial tight junction. So the epithelial tight junction is responsible for the movement of fluid and ions between the epithelium and the interstitium, and the endothelial tight junction is responsible for the fluid movement between the capillary endothelial cell and the interstitium. So this overall damage, to remember, ARDS happens only when there is both epithelial and endothelial injury. That's when this thing happens. So it's predominantly an endothelial injury. Like in COVID, we know it's an endothelitis. It's more the damage to the endothelium that leads to this. So the destruction of these endothelial tight junction, the occludens and the claudins and the adherence junctions is what is responsible for the function, for the accumulation of fluid inside the alveoli, and this leads to increased permeability to liquid and protein across the endothelium, leads to edema in the lung interstitium. From the interstitium, the fluid is then normally, the tight barrier properties of the alveolar epithelium will prevent it from going, but because the alveolar epithelial tight junction are also damaged, this fluid will now move into the lung alveolar capillaries. So this increased alveolar capillary permeability to fluid, proteins, neutrophils, blood cells is what is going to be result in the accumulation in the alveolar spaces, is what is responsible for the pathology of ARDS. So this is something which is easy to understand and follow. And eventually you have an injured alveolus, which is manifesting itself with this blue colored fluid here, which is just basically fluid filling the alveoli. And not only that, so the direct epithelial and endothelial injury is followed by a second wave, and that second wave is the inflammatory injury, which causes more damage. If it was just the exudative phase with just the fluids and just the alveolar phase, it's not going to be a problem. It is this exudative phase of the alveoli getting flooded, each and every individual alveoli getting flooded, but the more important thing is that it's not each and every individual, it's a heterogeneous distributions, and it is not a homogeneous distribution of the damage in all the alveoli, and that is what is very typical of ARDS. And the pathology of ARDS is going to show hyaline membranes, which is why the initial theory people was that this is exactly like the hyaline membrane disease of children. It is not. It is slightly different because it's heterogeneous as compared to the universal homogeneous sloughing of this thing. So that's why when you look at Professor Lackman and all, who came in the 90s and wanted every alveoli to open, you have to remember all his publications initially were in infant distress syndrome. And so to extrapolate those things to the alveoli and trying to open up all the alveoli is where these concepts come from. And this is not possible, may not be possible in ARDS to open up all the alveoli because it's a heterogeneous disease, and the loss of denuding of the surfactant and the membrane may not be universally happening as in everything. And eventually, if you're lucky, you repair the alveolus and you get a normal alveolus, and then the alveolar macrophages is taking care of all the debris, and then you're back to normal. But occasionally you can end up with excessive deposition of collagens, and as a result of which you can get into the fibroproliferative phase of ARDS. So that's what can happen, and that's something which is the thing. But we're talking about, when we talk about PEEP, when we talk about the management of using driving pressure to guide fluids, we're always talking about the first 5 to 7 days of acute lung injury, that is in the exudative phase of the injury. In the fibroproliferative phase, where there is not much, where there is a significant collagen deposition happening, and there's a significant, this underlying management of PEEP and driving pressure may or may not hold true, and we should not be trying to do any of those things on day 17, 18, when the lungs are stiff, and those kind of titrating PEEP, titrating of your driving pressure and all those things don't matter. So when you talk about PEEP and driving pressure, it is in the exudative phase of ARDS, when your lungs are flooded in a heterogeneous fashion, not in a homogeneous fashion as in this thing. We also need to remember that when you try to do PEEP titration and you find that there's a significant response with PEEP and the patient gets better quickly, you need to, or patient is not responding despite whatever you do, you have to worry about the mimics. And those are the mimics are eosinophilic pneumonia, diffuse alveolar hemorrhage, AIP, cryptogenic organizing pneumonia, AIP, Hammond-Ridge syndrome, and obviously the one which responds very well to diuretics is acute heart failure. So all these things need to be remembered and then taken care of. And the best way to understand the mimics is that if you don't have an ARDS risk factor as shown in the right side, if you don't have any of these risk factors, that means you didn't come in with the pneumonia, you didn't drown, you didn't have a pulmonary contusion, you don't have sepsis, you don't have pancreatitis, you don't have trauma, you don't have major transfusions, you don't have major drug overdose. Think of a mimic and then do a bronchoscopy or workup as required to identify the cause of ARDS. Right, and the more important thing is so obviously all ARDS is not the same, and we know that a subphenotype is there, which is what is important, and this is probably very important for knowing whether PEEP is going to work in certain patients or not. And we'll come to this at the end, that are all ARDS patients the same? And the answer is no. And the live study was basically one of the studies wherein they based a look at the radiological this thing into homogeneous and heterogeneous disease and tried to titrate PEEP and try to do the treatment, but they couldn't show any important outcome difference because of the fact that there was a significant amount of misclassification into the radiological phenotype. So there is an issue about how to do it, but there are PEEP responders, people who respond their PF ratio by more than 25 millimeters can be called as a PEEP phenotype or a PEEP responsive subphenotype. And maybe treatment directed at those people may have different effect than those people who don't have PEEP responsive. So this concept of a subphenotype is important to understand. All right, so with this preamble, and to understand that the main mechanism of physiology, the pathology is basically a diffuse alveolar damage, which is heterogeneous in nature, causing a flooding of the alveoli first by fluids and then by inflammatory cells, is what is responsible for hypoxemia. So as a result of which you have shunt physiology due to a perfusion of the unventilated alveoli. So the only way to improve oxygenation would be to get more alveoli to be ventilated. And we'll talk about it. There are other mechanisms opening up a patent foramen ovale and leading to right to left shunt. And the incidence is as high as 20% in ARDS. And dead space physiology due to diffuse hypoxic pulmonary vasoconstriction as one of the reasons for the hypoxemia that can happen in this thing. But what we are targeting in the early exudative phase is the shunt physiology due to perfusion of the unventilated alveoli. And that is the aim of when you have hypoxemia. But remember, hypoxemia never kills. It is the multi-organ failure. It is the villi that kills. So we need to be careful about what we want to do. So the goals of mechanical ventilation can be broadly brought down into three things. That is to ensure adequate oxygenation, maintaining an adequate pH irrespective of PCO2, and we'll talk about these goals. And third is obviously preventing villi, and we'll talk one by one, and then we will say how we're going to do lung protection with PEEP and with driving pressure management. All right. So before we go into hypoxia, can we do permissive hypoxia? And this is also a failure. Remember that multi-organ failure is responsible, and tissue hypoxia is the leading cause of death rather than just hypoxia. But we know in ARDS, it may not be very great to keep the P saturation very low. In 88 to 90% saturation is the goal, that is bare minimum, that is required to be achieved with the least toxic amount of FiO2, which is less than 70% for more than 24 hours. So we need to achieve that goal. So permissive hypoxia may be an option, but not early on in the disease. When the exudative phase, when the patient body hasn't got adapted to it. 17 days into the fibroproliferative phase, maybe letting a SAT of 85% with the least amount of oxygen would be an okay idea at that particular point in time, or even 80% is at that time. But as long as we give time for the body to adapt, hypoxia is okay. If we don't give time for the body to adapt, then especially in an acute exudative phase of ARDS, permissive hypoxia may be harmful. So that's something which we need to be careful about and need to understand that. So how do we ensure adequate oxygenation? One is obviously simple, keep on going up on the FiO2. The only problem with that is you kind of come to a stop at 100%. You can't go beyond 100%. There's nothing you can do about it. So the second, what you need to do is to increase the mean airway pressure. What happens when you increase the mean airway pressure? It allows the redistribution of gas from the more compliant alveoli to the less compliant alveoli, so that more and more alveoli will get air into it and may get oxygenated, and so the shunt fraction will go down. So the QS by QT will go down. So there are only three ways in which you can do that. So that is by increasing tidal volume, increasing inspiratory time, which is what we do in inverse ratio ventilation, or by increasing PEEP. So now if you look at the history of mechanical ventilation and say how did we arrive at this thing? So the initial ventilation was in the polio epidemic. Though it was very easy. Lungs are not affected at all. It's a disease of the muscle. So you just have to put a tracheostomy and then put the ventilator on, and that's all. They don't have a drive, they don't fight, and it's very easy. Only when the anesthesia ventilator moved into the anesthesia OR also wasn't very difficult, only when it moved to respiratory failure. But even in anesthesia and prolonged OT, they noticed that there was a lot of atelectasis because they used to use a nomogram to conduct to identify what's the requirement of the minute ventilation, and the tidal volume will come down as your respiratory rate, and there's a nomogram to adjust the respiratory rate and tidal volume. So eventually collapse and atelectasis would happen. So the best way they realized is instead of giving, in the pressure controlled ventilation, they couldn't give PEEP. So the only way they could do was to either give a sigh breathing or to increase the tidal volume. So as a result, in the 60s, you had a patient who would get almost 12 to 15 ml per kilogram of tidal volume as a normal thing, because that's the only way to prevent passive atelectasis in the anesthesia in the postoperative ICU. And as a result of which, this got extrapolated to the ICU with hypoxic respiratory failure. We're trying to increase tidal volume once your FiO2 has reached toxic levels of 70%. But then they realized that that's not possible. So that's when the Ashbaugh and Petty came up with the idea of increasing the mean airway pressure by increasing PEEP. And we already knew PEEP would work, but the cardiovascular effect of Cournot's theory in 1948 that PEEP would cause a significant fall in cardiac output prevented people from using PEEP till about 1967, when Ashbaugh said that this could be useful. So PEEP got into prime time at that particular point in time to improve oxygenation. And this was done predominantly to prevent the passive atelectasis that would happen. And that's why the name of ARDS prior to 1967 was congestive atelectasis. That it's a wet lung, it's flooded, and there's a collapse in the lung. So increasing the mean airway pressure, and it did work wonders. There's no doubt that it would work, and PEEP would improve oxygenation. And then PEEP would improve oxygenation. And so the ARDS ventilation in 1970s had a goal of PaO2 of 60 to 70, 100 ml of mercury, on FiO2 less than 0.55, tidal volume of 12 to 15 ml per kg as a PEEP, ranging from 27 to 54 centimeter of water. So these are true numbers in the 70s, what they used to ventilate patient with ARDS. And a consequence was that people thought that people even did not respond even that. And they thought their patient had progressive ARDS. But now we know that this is volume trauma. But in those days, we just thought that this was villi. But we didn't know that in the 70s, nobody knew that this was, they just thought the disease was going off. And that's what happened. So we also very commonly see this in small nursing home where people don't understand. People put them on pressure control of 30, PEEP of 20, and forget about an ARDS patient. And they say, oh, the disease is going bad. And that's an easy way, but that is what happened from 70 to late 80s before we realize what's happening. But the compromise that everybody realizes with a high pressure like this is the barotrauma, and that was automatically. But more importantly, what they noticed was the hemodynamic compromise, and the hemodynamic compromise is what led to this discussion about what is an optimum PEEP in 1970s. So the optimum PEEP in 1970s was identified by Peter Suter and colleagues by looking at the PaO2 shunt fraction, compliance, and oxygen transport. And you realize that there is a best PEEP beyond which the oxygenation will continue to improve, but the shunt fraction will go down. That means your total compliance is also going down, and your oxygen transport eventually will go down. That means your SVO2 will start falling, and you will eventually end up doing more harm despite an improvement in PaO2. And that used to be the best PEEP in the late 70s and early 80s, is that you will put a Swan-Ganz catheter, you will measure the SVO2, you will measure the shunt fraction, you will measure the compliance on the ventilator, which is very difficult in those days because the inspiratory pause button wasn't available. And you will try to do PEEP titrated to mainly to QS by QT and to SVO2. And that's what was being done. And this is what was known. And we really realized that on the component of the compliance was this thing that it is the oxygen transport was getting affected at the higher PEEP. And it is even the dead space fraction also gets worse, and the compliance and the output. So the last three, everything gets worse after a particular best PEEP. And that best PEEP is eventually was found out using cardiac output by Swan-Ganz catheter in the early 80s. So ventilation and Swan-Ganz catheter and ARDS grew up together in the history of ARDS ventilation and ICU critical care medicine. So that's how this was happening in those days. Then these were the experiments in the 1980s that was being done by Dreyfus et al. Late 80s animal experiments with rats, which said that if you were to ventilate somebody with just 5 minutes of high airway pressure, you will realize that the whole lung is flooded, and by 20 minutes, you are basically got ARDS again. You just have congestive and edema fluids fills the tracheal cannula. And this is what we have seen in many of our patients when they die. This is what is happening to them. And this is because of high pressures. So they did this experiment and they found out that the extravascular lung water, which is measured by the the extravascular, the total water content by total body weight of the rat, and the permeable permeability by dry lung weight, by body weight, by the albumin space, by technetium scans, and that which is nowadays we call as permeability pulmonary edema. All this will increase in 5 to 10 minutes as you increase the prepositive pressure, and the peak pressure goes up from 15 to 45 millimeter of 45 centimeter of water. So that's all it takes. And this will now realize that it's not the disease that was progressing when you use PEEPs from 20s to 50s. You are basically increasing the mean airway pressure to such an extent that you are leading to a damage which is exactly similar to the electron microscopic picture of what I showed you, that is diffuse alveolar damage. So ventilator-induced lung injury because of this kind of positive pressure will lead to the same damage as what would have happened by ARDS and the disease. And that's why in those days, in the absence of these kind of studies, people couldn't distinguish whether it was just disease progression or what was happening. We now know it, but in those 19-20 years before all these data came up in the late 80s, people just thought that the disease was progressing. They didn't understand that it was harmful ventilation that was happening. And whether this was pressure causing the effect or was it the volume, and this was a seminal paper published again from the same group from Dreyfus, which really looked at if you were to do high pressure, high volume, or a low pressure, which is basically high tidal volume ventilation, which was the standard norm in those days, or a low pressure, high volume ventilation, which is an iron lung, or a high pressure, low volume, which is by strapping the thoracoabdomen so that your lung don't have too much tidal volume. It is obvious in these three diagrams that the last box, the HIP LOV, is the one which is showing the best effect as far as the extravascular lung water is concerned and as far as the permeability pulmonary edema is concerned. So thoracoabdominal strapping, that is letting the pressure versus volume. So this laid the foundation of the concept of volume trauma, and we now know that that is what is important. So this led to us to think, and okay, let's not do this anymore, and let's look at low volume pressure limited ventilation. And this led to the second goal of this thing, which is called as permissive hypercapnia. This was a paper published in 1991 by Hickling in intensive care medicine, which looked at significant mortality benefit with low volume pressure limited ventilation. In this, they tolerated a high PCO2, kept the pH more than 7.15, and they gave the concept of permissive hypercapnia and a low tidal volume, a low volume pressure limited ventilation, allowing for the PCO2 to rise up with this, which is a consequence of the low tidal volume, and allowing the CO2 to go up is called as permissive hypercapnia. So Hickling's publication in 1991 is what led to the fact that we understood that volume trauma was important, so volume needed to be limited. And then the subsequent ARMA trial in 1999 approved it beyond doubt that 12 versus 6 ml, 12 is harmful, 41% versus 34% mortality, and therefore we all have moved to a low volume pressure limited ventilation. And what is the limitation of pressure? Plateau pressure of 30 was what has the ARMA trial has shown us. So this was the concept number 2, but we now don't know what is the safe limit of PCO2. Initially, it was thought that up till 60, beyond which is where the brain creates a problem. But we now know that even beyond 48, it may be an issue with the right heart flow, and therefore the right heart might get affected if your PCO2 starts going up. So we need to be careful with the PCO2. But as of now, we still would take a PCO2 of 55 to 60 and a pH of more than 7.1. And the last goal of ventilation is to protect the lungs, and that is, as I said, to prevent the volume trauma and obviously the barotrauma. So limit the pressure, limit the volume, which is now obviously now the question was which one is more important. So to keep an airway pressure with a plateau pause pressure of less than 30, or was it important to keep the tidal volume low as shown by the Dreyfus's study with the strapping of the abdominothorax? So this was very always difficult to assess what is more important, to keep the plateau pressure or to keep the tidal volume low. But this is better understood if you understand. And then the other concept of atelectotrauma, biotrauma, and now ergotrauma as the 5 main things which can cause harm to the patient. And so when we ventilate, we want to prevent the stress and strain to the lungs. We want to prevent atelectotrauma, and that's where PEEP comes into a lot, other than the oxygenation that we talked about. And then we talk about how to use to diminish this by using the concept of driving. How does the concept of stress and strain translate to driving pressure? So let's look at, so the idea when you want to protect the lungs now, instead of looking at and saying that, oh, we want to prevent volume trauma, barotrauma, and so on and so forth, we want to say that we want to avoid excess stress and strain while ventilating ARDS to prevent villi. And we want to prevent excess stress and tidal strain by also decreasing the respiratory rate, which also translates to decreasing the power. And we also want to decrease the flow in which it goes in. So that is again the concept of the power. So we want to avoid excessive stress and strain while ventilating. And mechanical ventilation will cause villi by applying excessive force to the lung parenchyma. Because you're blowing air into somebody, it is going to cause the lung parenchyma to be under stress. So how much? And the best way to measure that stress is the pressure inside the airway and outside the airway, which is what is called as a transpulmonary pressure. That is the alveolar pressure minus the pleural pressure would be the best measure of the stress. While so the stress is basically the force that you need to apply above the relaxed baseline, which is what. And the strain is what is going to happen to the resulting elongation that will happen as a result of this volume change. And this is the concept of stress and strain. So you want to ventilate to protect the lungs. If you look at it, the stress of the lungs that you have with positive pressure ventilation depends on the specific elastance of the lung, multiplied by the change in volume above the FRC. That means what is the tidal volume that you're generating above the FRC to cause strain. And now you can put the respiratory rate and the flow into this, and also say that those all will generate this thing. A normal lung elastance is about 12 to 13 centimeter of water. So this is what you want to prevent. You want to keep the transpulmonary pressure the lowest, and you want to change this delta V by delta FRC as also the lowest is what you want. So how do you decrease strain? Is by this decreasing the tidal volume, that is ventilate a baby lung. Remember, the lung of the forced vital capacity FRC of a patient who's got ARDS is about somewhere between 500 to 1.5 liters. That's low, and now as compared to 3.5 to 4.5 liters in this thing. That's why we call it a baby lung, because the FRC of an ARDS lung is the same as that of a 5-year-old child. So that is how low the FRC is in a patient with ARDS. So you want to decrease strain by decreasing tidal volume. And as I said, this is the baby lung. The baby lung is created because there are certain areas which are completely collapsed, certain areas which are edematous and partially collapsed, and certain areas which are fully normal. And that's why so you just want to ventilate this little normal area, that is the white area that you can see on this, and that's a baby lung. So the FRC of the entire lung is only about 500 to 1500 ml as compared to what you would see here. So these are difficult to ventilate, and the glorious aim with PEEP is that we want to open this. This would have opened up if it were a passive collapse, but this is not a passive collapse. It's a lot of inflammatory edematous fluid with neutrophils and everything. This is not going to open up easily. So that is why opening up these alveoli might be a pipe dream. And that's why this is not work. Maybe this area might open up, which is edematous, but this area the best way to open this area is to prone ventilate them. The PEEP may or may not be of much use, because then you may have better shape matching, and you have better gravity and shape matching happening, so that you have better ventilation perfusion ratios to that part of the lung. So proning is the only way to take care of this dependent collapse. Rather than, it is not a congestive, it is not a passive collapse, which happens in a post-operative patient, perioperative patient. So this is a different inflammatory edema, dense consolidation. And we know that the way to decrease strain is by the low tidal volume ventilation, and to decrease stress. Now, stress can be two things: global, which is by just measuring the plateau pressure. That means you press a pause button, you have no airflow, and you see that the plateau pressure is less than 30, and now you will say that the goal is 27. And this global pressure can also be looked in the part as driving pressure, and because eventually driving pressure is nothing but change in volume, plateau minus PEEP, which is the compliance of the lung. So you're not going to be, so stress can be, driving pressure is only one way of looking at whether there's adequate, what is the amount of stress that your ventilation is giving. So if you were to ventilate somebody and as you increase the mean airway pressure by either increasing PEEP or tidal volume, if your driving pressure is low, it is not harming the patient. But we know that beyond 8 ml per kilogram, it will harm the patient. So we don't want to go beyond, but PEEP or mean airway pressure can be increased as long as your driving pressure is less than 13. And that basically tells you that more and more whatever PEEP or higher mean airway pressure that we are using, you're able to dissipate that pressure into the unventilated alveoli, and as a result of which the compliance is, that pressure is not dissipated into the open alveoli, but it is able to be spread across the air, and this is going to be a global marker. And for locally, we want to decrease the stress, and we'll talk about whether we can use paralytics and to prevent the pendulum if that happens. By locally, we want to keep the alveoli open, and that is talking about PEEP and recruitment. I'll not talk about recruitment, but I'll talk about PEEP and how does PEEP work. So let's look at driving pressure. So driving pressure is nothing but tidal volume into elastance. And elastance is equal to tidal volume into plat pressure minus PEEP divided by tidal volume again. So once you cut off the tidal volume, you're left with plateau pressure minus PEEP. So driving pressure is also therefore related to elastance and strain, which is what we had told in this diagram, in this one. So that it's the same equation. So stress is equal to elastance into strain. So driving pressure is also kind of boils down to the same thing, that it is equal to plateau minus PEEP. So driving pressure is the same as is related to elastance and the tidal volume. The only thing is it's not above the FRC. So you are basically related to nothing new. The concept of driving pressure is nothing new as far as why we lay some accommodating. What we are trying to say is that plateau pressure somehow doesn't match with everybody, and that's the paper that the Amato group and the Toronto group looked at all the previous ARDS thing, and they found that it is the best predictor of villi in patients with ARDS, as well as in patients undergoing general anesthesia, in whom the rate of pulmonary complication was associated. But obviously, the evidence for this is based on statistical mediation analysis, and we don't have a prospective study as of now to say that adjusting the driving pressure, and if a high driving pressure of more than 15 centimeter is independently linked to ARDS mortality, and any measures to bring down driving pressure when it is high is going to improve mortality. That data is not there. So in contrast to adjusting tidal volume for ideal body weight, driving pressure adjusts the tidal volume for the compliance, and it is a change in tidal volume related to the static compliance of the respiratory system, or the pressure differential required to inflate the lungs, that is plateau minus PEEP is what you're measuring. So the driving pressure is just the only difference between driving pressure and low tidal volume ventilation is low tidal volume ventilation is 1 second. Sorry about that. I had to let my dog out. So it is change in tidal volume related to the tidal volume is to the ideal body weight, while driving pressure adjusts the tidal volume for compliance. And retrospectively, if you look at this data that was published in NEJM, you will see that some high plateau pressure is not always risky, and low high PEEP is not always protective. So that means that what mattered was that whenever you increase plateau pressure, or whenever you increase PEEP, or whenever you decrease either of them, as long as the driving pressure remains the same, that is plateau minus PEEP remains the same, you're going to have a good outcome. So optimizing ventilator settings to achieve a driving pressure less than 15 may be the present preferred target. And this basically this is based on 9 trials prior to the up till the ART trial, I would say, or just before that, and it has looked at this, and this found that the driving pressure is the best variable that can. Obviously, this is a statistical analysis of a retrospective, robust data, but there's no doubt that, because it is obvious to us that just some people would not do well even with a high plateau pressure, and some people would not do better with a high PEEP. So it is somewhere in between. So it is the plateau minus PEEP that is what makes all the difference. As long as the plateau minus PEEP is less than 15 and preferably less than 13, you will probably are achieving what you want to do, not to overventilate the small baby lung. And that's exactly what the message is. So driving pressure is a euphemism. I won't say euphemism, it probably is too strong a word, but it is another way of looking at stress and strain. Instead of looking at plateau pressure and tidal volume, with knowing that low tidal volume works, limiting plateau pressure less than 30 versus limiting, which is adjusted to the ideal body weight, versus limiting tidal volume adjusted to the compliance of that particular lung, which may be 15, less than 15, which is the driving pressure, may be a better option. So this is the concept of protecting the lung stress and strain by using an optimal driving pressure that we want to understand. All right, so next was to decrease the stress locally by keeping the alveoli open, and that is using PEEP. And this has always been the concept of open lung ventilation, where we know that if you were to use large tidal volume and no PEEP, you're going to have repetitive opening and collapse of the lung, and this is conventional ventilation. And if you have protective ventilation, that means you have low tidal volume and a low PEEP and a high PEEP, which prevents the airway from completely collapsing, and the excursions are minimal as compared to this. And this is going to lead to prevention of, to be protective to the lung. And the main protection is obviously that it does, the low tidal volume is going to prevent volutrauma. The repetitive opening and closure is what is going to prevent the concept of what is called as atelectotrauma. And this atelectotrauma concept comes from the Mead's model of lung stress. This is again published in the late 70s and early 80s, which looks at the fact that at the interface between a totally collapsed unit in the black and the low in the high stress units, which are the intermediate stress and this thing, at the interface between a collapsed alveoli and the highest lung stress is always concentrated around this area, around the totally collapsed units. And that is why it is important to keep the lung not at the total lung capacity of 7,500 ml and not at the 2,500 ml, somewhere in between, so that the stress and strain is the atelectotrauma, the repetitive opening and closure between that is happening here, is mitigated. And this this lung stress is obviously going to be even worse in the area of collapsed tissue, especially when we know that the dorsum part of the lung is going to be collapsed, and the posterior, the pressure transmission will not be uniform because of this collapsed lung. And in the presence of lung injury, injured lung areas act as solid and do not transmit the regional forces generated by the diaphragmatic contraction that you see, and as a result of which you will have certain areas which will have different pressures, and you will have the transpulmonary pressures which are different in different areas of the lung. And so this is one of the other reasons why, having a opening up these alveoli might be important to prevent that from happening. So the concept of opening up is to prevent these two states of happening, that is going from fully open to fully closed, and this is repetitive atelectrotrauma, and this is Slutsky's, and this results in significant increase inflammatory markers, significant increase concept of problem. So therefore, the concept of PEEP mitigating villi by recruitment of alveoli, which should have collapsed on expiration, and improving end expiratory lung volume and decreasing atelectrotrauma is what was the proposition which was now coming up when we knew that high PEEP of 27 to 60 was not good, and it was causing a low cardiac output and tissue hypoperfusion. So we realized that this may be the mechanism in which PEEP might mitigate the villi, and increasing the number of aerated alveoli by giving PEEP may result in decrease the tidal stress and strain, which is reflected by increased compliance. So you really need to get that optimal PEEP for the best compliance, and you need to get a PEEP to prevent the lung from collapsing, and this can happen by recruiting and then holding the PEEP there to prevent it. And so giving a larger amount of PEEP might be promoting more homogeneous ventilation, thereby decreasing stress and strain at the margin between the aerated and collapsed lung. So this is how PEEP mitigates villi, and that is what is theorized. But has this been successfully done in clinical practice? And that's what we need to look at, whether this is what led to the concept of open lung. So you recruit the lung so that all the alveoli are open, and then you give adequate PEEP so that they do not repeatedly collapse with expiration and improving. So basically, you're giving a large tidal volume for a brief moment of time, which is recruitment, and then you hold the lung by preventing it from collapsing by giving a large amount of PEEP, and that's what is called as an open lung approach. And this was the fully opening of the lung and will minimize atelectrotrauma. And we know that alveolar recruitment maneuvers are now no longer recommended because of the ART trial, which has shown that a sustained high inflation recruitment maneuver actually increases mortality. So we now are left only with the PEEP. And we now know that with the high PEEP versus low PEEP, 3 RCTs have compared them. The alveoli trial, the Express trial, and the LOVES trial, and none of them have shown clear mortality benefit. So in moderate to severe ARDS, maybe particularly in a PEEP responsive group, that is when the PF ratio improves by more than 25, there might be a benefit. But if you were to now look at just to give anybody 20 PEEP versus 10 PEEP or 12 PEEP in a severe ARDS, 15 versus 20 or 12 versus 20, you don't know which is the right PEEP without monitoring. You are probably not, you're better off doing the conventional ARDS network table and doing the low PEEP as compared to the high PEEP. Though there's not much, you will say the difference is maybe only about 5 or 6 centimeter of PEEP difference pressure, but that's significant enough to know that in high PEEP, there is no benefit and there might be harm. So maybe in a selective group of patients, it might be beneficial, that is PEEP responsive, but others it will not be responsive. So what do we do nowadays? We basically can look at PEEP titration. That means a stepwise increase in PEEP followed by a decremental of 2 to 5 minutes every 2 minutes while checking plateau pressure or driving pressure and monitoring changes in compliance. Does this help? We still don't know whether it is going to help or not, but this is an option of titrating PEEP if you just don't want to give random. But what we do, and when you look at it, what are you trying to do is it's not the lower inflection point that you're looking at. What you're looking at is basically the airway opening pressure. So when PEEP levels, when you raise it to a particular and then drop it suddenly, you will realize, as you can see it in this arrow here, that the airway opening pressure, that means the airway pressure starts to rise, but the esophageal pressure and the lung transpulmonary pressure takes a longer time and the tidal volume takes a little after. So it is this part of time from the beginning of the airway, the first inflation is basically meant to just open up the individual lung units and may not be just to open up. And so this is the airway. It is not basically, we talk that this is in a pressure volume curve. It is not the lower inflection point. What we are looking at is this. It is the airway opening pressure that is more important, and to prevent the airway closure and de-recruitment of already opened alveolar units. So that might be one way in which we can think of doing this. You can also look at titrating PEEP based on respiratory mechanics, which is all in the esophageal manometry, because as I said, it is if you look at this, looking at the esophageal pressure becomes very important, and to titrate this properly we need. But then we have 4 trials that have compared these strategies: EPVENT 1, EPVENT 2, and Pintado's trial and ART trial. And ART trial was actually, EPVENT was a positive trial, EPVENT 2 was equivocal, and ART trial actually showed a significantly higher mortality. In this, when you titrate PEEP, you monitor the end inspiratory pressure, you monitor the end expiratory pressure, and you monitor the transpulmonary driving pressure. So your goal is to keep the end inspiratory pressure less than 15, and expiratory pressure slightly 0 or slightly positive, and a transpulmonary driving pressure of less than 10 to 12 at all time. And if you do this and with using esophageal manometry and specialized ventilators, you still have not really raised to any outcome benefit in any of these studies. So PEEP titration based on these kind of inflection points, airway occlusion pressure, stepwise increasing, high PEEP, low PEEP, we really don't know where we are. So as of 2023, we just say, pick a starting PEEP and just use a ARDS network trial table, or use the Gattinoni method. Gattinoni method is simple. If you're mild ARDS, anywhere from 5 to 10, moderate 10 to 15, severe 15 to 20 PEEP. And ARDSnet is very simple. Divide the FiO2 by 5. You get this thing. So if you have 100% FiO2, you require 20 PEEP. And if you have 80, you require 16 PEEP. So like that, you can easily go ahead and do that. And this thing. But more importantly is think about what harm you can do with PEEP. And as I said, this 1977 paper from Suter clearly points out that the tissue perfusion will go up, the SCVO2 will go down, and the right heart is going to be harmed. So think about that, and then think about, yes, okay, I'm not harming this patient, so I'm just going to start a PEEP. Then I'm making sure that the PEEP is not harming the patient. Then I'm saying, can I increase the PEEP? Thinking about the benefits of PEEP, which we just talked about, that it's going to prevent atelectrotrauma, and how am I going to best do it? So this is how we set PEEP in 2023. So you're going to think of the potential harms, and you're going to be monitoring either a continuous monitor for RV dysfunction with an echocardiography, looking for the D sign and looking for the dilatation of the RV, or you can use a Swan-Ganz with a continuous RV cardiac output, which will tell us whether the RV's output is falling or not. So this is one of the things that we can think of. The benefits of PEEP, then when we say that, should we be doing what we now commonly would say is that, okay, I'm not harming, PEEP has not harmed the patient, so I'm then going to be using the driving pressure to guide my PEEP. So I say I'm on a patient with a severe, I have a patient who's got a 70% FiO2, and as per the ARDSnet guidelines divided by 5, so I've got about 14 of PEEP ongoing. So and I'm not harming the RV, and I have realized that the good as cardio-hemodynamics is good, there's no hypotension, the SCVO2 is good, and I'm looking at the fact that can I increase the PEEP to get best prevent atelectrotrauma and prevent this thing. At this point in time, you might think of measuring the driving pressure at different levels of PEEP, or this is called as the DP by compliance guided measure, or measure the compliance and see if the DP increases at a higher PEEP, that means it's a decreases at a higher PEEP, it means a success. If DP increases with a higher PEEP, that means you're failing. And if DP is equipoise, then you don't know what to do with it. So this is one of the ways. So if you have a continuous pause given on a ventilator, and you can just follow it up and see as you incrementally increase PEEP by 10 and then follow it by 2, you see the best driving compliance, and you can use that in a particular subset of patients where there is no harm being done with PEEP. And that's probably what is to be done. As I said, respiratory mechanics guided may not be useful. Empiric high PEEP versus low PEEP may not be useful. Maybe compliance guided may be the use thing. But you have to remember the caveat to this guided PEEP titration. So again, compliance and driving pressure can be paradoxically improved by intra-tidal recruitment, de-recruitment. Therefore, concluding that there is harmful over-distension just on the basis of DP and compliance is not right. You need to look at the stress index, as you can look at the pressure time scalar. You have to always in any medical field any monitoring tool, you always don't rely only on one data. So over distension or under distension can be, you're looking at compliance in DP and you're also looking at the stress index at the same time, may be useful to do it on this thing. So over distension should be assessed by alternate methods also. There are other caveats. As I said, the compliance is not only from the lungs, because also from the chest wall, and changes in measured compliance may reflect changes at the level of the chest wall and may not necessarily reflect at the level of the lungs. We have to be careful. And then regional over distension and regional deflation may not alter the DP, and you might think that DP is getting better or compliance has remained the same, but that is because certain areas of the one which were already previously collapsed are now distended, previously distended are now over distended. So you might again become neutral. It's like when you have emphysema and fibrosis together, your pulmonary function test can be normal, isn't it? So it's something similar where you're altering your regional over distension and collapse may alter the DP and compliance. And as a result of which, when you use, so these are the caveats that you need to remember when you are guiding PEEP with using driving pressure and this thing. Again, you can use something like this recruitment deflation index. I'm not going to talk too much about it because I personally am not, you need to have this ability to measure the exhaled tidal volume, find out the recruitment, and then do it. Or if you have equipment like the EIT, electrical impedance tomography, to identify what is again do a decremental PEEP and find out which is the best PEEP where you have the best amount of lung available for preventing atelectro trauma. So as of today, I would still say set the PEEP initially in ARDS as per the guidelines of the ARDS network trial or the Gattinoni method. Look at whether your PEEP is doing harm to the cardiac output or tissue hypoperfusion or to the right ventricle. If not, then use the driving pressure with a decremental after increasing the PEEP from the baseline by 10 and then stepping down and looking at each different situation, looking at what is happening to the driving pressure and finding the best PEEP wherein you have the best inflated lungs, and then stopping and then letting the lung rest and taking care of it might be the best way. So I'm going to summarize quickly saying that we are back in the 70s. PEEP is titrated to the best cardiac output nowadays. PEEP should do no harm, protect the right heart. PEEP benefit phenotype, there is an increase in 25 PF ratio by 25. PEEP titration to DP in case you want to derive benefit from PEEP after you have ruled out the harm that you're doing. And driving pressure guidance is the best way to understand what is the causative factor of villi, how the stress and the strain affects the lung, in addition to the power that you're also giving the ergotrauma concept, which we can discuss sometime later. And as of now, therapy directed at driving pressure doesn't exist, but treatment should be done in such a way that your driving pressure is not more than 15 by whatever PEEP, whatever mean airway pressure you want to do, and taking an understanding that once you are beyond the 5 days, 7 days, and remembering the Eolia criteria that once the CO2 starts going up, you better think of, rather than the hypoxia, I prefer the Eolia criteria for ECMO as the better to do it with the PCO2 and pH rather than the PO2 and the saturation as a better way of doing it. Thank you very much for your kind attention. I hope I was lucid enough and finished 10 minutes in. I know I probably finished 10 minutes in advance because these. I hope that's all right with.
Yes. Thanks a lot, sir. Actually, I think that those people are practicing for the critical care is near to their heart about the PEEP. A lot of people ask the questions about the patients we kept on ventilator. We given the PEEP, and by increasing the PEEP, patient having hemodynamic instability and patient not having improvement of saturation. I think you pointed very correctly about the question about the high PEEP or low PEEP. I think you are given the answer by initially thought process was there whenever increase in the PEEP, there increase in oxygenation and the increase in delivery of the oxygen to the tissues. I think after listening to your presentation, this doesn't hold true. That every time people getting benefit is not correct. Now, just wanted to ask the question, sir. In ARDS network trial, they shown that low tidal volume is improving benefit for the mortality. But why not with the PEEP? Just for the general audience, for the people, because we are doing so much of work on the PEEP, and ultimately PEEP is improving the oxygenation. Why it is not translating for the improvement in the mortality for the patient?
Very simple answer. The mortality in ARDS is not because of hypoxia, it is because of MODS and villi. So ARDS mortality is not because of hypoxia. Hypoxia doesn't kill in any of these situations. So That is why the mortality benefit of any measures to improve oxygenation. That's why I said, even when I look at ECMO, I'm not looking at oxygenation. I'm only looking at the PCO2 and the pH. That is what is going to kill you, because that's what is the problem. So it is oxygenation. If you target oxygenation, you're never going to be showing benefit. So PEEP, when it looked at oxygenation, did not show improvement, did show benefit. That's why this entity of ARDS was born. But a PEEP which you keep on increasing, which causes harm to the right side of the heart, is bad, is what Suter proved in 70s. And then subsequently, we realized that it is the large amount of mean airway pressure with the large tidal volume, because in those days, as I pointed out, historically, 12 to 15 ml per kilogram was what was commonly used in the 70s to prevent passive atelectasis. So when 12 was compared to 6, that's why if you look at the ARMA trial criticism, it is obviously who uses 12. Even in the early, by the time the trial was done, people had moved down to 10 ml. So if you had done 10 ml versus 6 ml, you wouldn't have been, versus 8 ml, I'm guaranteeing you they wouldn't have been able to show a difference. So it is only 12 ml versus 6 ml that showed a huge difference. So yes, what it changed, the ARMA trial did, was to change the practice of using large tidal volumes as an anesthesia practice in the OR, in the olden ventilators, pressure targeted ventilators, where you didn't have an expiratory filled PEEP, where you were the only way you can improve was to give either sigh breathing or to give large tidal volume. So it basically put an end to an era of respiratory therapy, an end to an era. It is not what we are thinking. People who have grown up in this generation are not able to understand the sequence of events. But yes, so oxygenation target will never work.
Absolutely correct, sir, what you told, because we are doing ARDS, multi-organ involvement is there, so that only keeping target of oxygen will not improve. One of the question is there, sir, in APRV mode, the ventilation parameters for reducing the driving pressure as the patient BPR, and what will do titration cases of APRV mode?
So again, HFOV, APRV, these are again controversial. These are the open lung approach. So as I said, there is no benefit in these things other than we have known with HFOV. In fact, now we know with high frequency oscillatory ventilation, where you keep a very high mean airway pressure, isn't it? The average mean airway pressure is kept at 22 to 24. So when you use APRV, there is nothing called a driving pressure. You are targeting a mean airway pressure. So when you're using HFOV or drive this thing, you're using a mean airway pressure. And we know that the lung gets damaged once the mean airway pressure. Subsequently, the stress that the lungs can take is about a mean airway pressure of about 21 to 23. So we know that's the pressure at which the alveoli really get stressed and fractures happen, alveolar stress fractures happen. So when we do APRV or HFOV, which is basically you want to keep the mean airway pressure less than 21. That's the goal. So driving pressure concept will not apply, because you keep the low PEEP cable, the high PEEP time and the low PEEP time. The low PEEP time would be almost zero. So there's nothing called a plateau minus PEEP here. So that concept of driving pressure is not valid in APRV or HFOV.
That is there. And so what is you just mentioned about the utilization of the driving pressure and the compliance, the concept for
both DP and compliance are the same. We always used to titrate PEEP to the best compliance. That means you keep on increasing or decreasing PEEP. So incremental PEEP and keep on increasing, or decremental PEEP. So the classical, when Dr. Lachman from South Africa, he came in 1999 to India for the for the IDCCM Criticon. He would demonstrate that he could get the PO2 down up to 550. And then you start, so you'll say ARDS, you start off with a PF of 100, you start giving them, recruiting them, get up to a PF of 550, and that's your best oxygenation. So then you start decreasing, and then you titrate down your FiO2. So there used to be this model of opening up all the alveoli that would come to. Then we realized that that's not a great model. Then we said, okay, we should titrate it to the best compliance. So driving pressure and compliance are the same thing. It is just dividing the plateau minus P versus tidal volume divided by the this thing. So compliance is you measuring by doing a plateau pressure and then dividing it with the tidal volume. So it's the same concept. So I said the pitfalls of driving pressure and or compliance, that's why I said it's to be the same. You can still have regional overdistension and you can still have regional collapse. So, and the chest wall also comes into play because you're measuring it outside in a lung which is inside the chest and the lung wall. So compliance guided PEEP therapy should be the third part, or that is the only thing we can do now. Once you are say on 15 of PEEP and 100%, 60%, 70% FiO2 or 80% FiO2, and you want to say, should I go to 20 or 24? And that decision has to be based on the fact that If I go to 20, is my compliance or my driving pressure getting worse or better? If my driving pressure and compliance are getting worse, then I'm okay in going to 20. If not, I just stick to 15 where I was.
Yes. What we understand, the concept is there about whatever changes you are doing on the ventilator settings, ultimately monitoring about the driving pressure is very important. Whatever the changes, either you are changing for the tidal volume, the PEEP, the respiratory rate, everything is there. If the driving pressure is going more than 15, then definitely that setting, maybe a high PEEP or low PEEP or tidal volume, will be not useful. We were just wanted to, sir, the role of ultrasound. What will be the role of ultrasound for this the patients to monitor? In addition to the for monitoring of driving pressure, whether we have any advantage for monitoring the ultrasound? Because last slide is shown about the electrical impedance, the tomography, EIT, but I think is not available everywhere. But the dramatical representation what we shown is just like ultrasound. If you're using an ultrasound guided therapy there for the driving pressure and compliance, will be useful.
Correct. So you can use things, as I said, compliance. You can use an LUS, lung injury score, with an ultrasound and saying whether the lung injury score with the number of B lines in each area is just getting better or not. People are doing this, but as I said, this has never been shown as of now to improve this thing. But yes, if you are doing it, as I said, what I would suggest is that whatever needs to be done, don't use only one. So similarly, the way we say we're pointing towards caveats to using only driving pressure. When you titrate up titrate PEEP or down titrate PEEP, you always have to go either use the stress index, either use the ultrasound, either use the EIT. You got to use something in conjunction with it. And definitely the ultrasound comes in most handy in making sure that your RV is not getting affected by this. So I think the ultrasound of the lung and heart are absolutely important whenever you are titrating PEEP. Both by looking at a lung injury score, by looking at the amount of B lines, is it coming down in certain areas, or regionally certain areas is increasing, and so on and so forth. But this has not been, what I would say, streamlined, or this has not been thought of, or has not been as of now published to say that guiding the PEEP to a lung injury score or a amount of B line pattern is going to be beneficial. But yes, using that along with the compliance or driving pressure may be a good idea.
I think only the over distension by doing a lung ultrasound will not able to understand. But if you're doing an echo and seeing the right sided pressure, definitely if over distension is there, the RV pressures are increasing, that will give an indirect idea for we are happy causing an over distension of the lung.
Correct.
The one more thing is there about some of the questions are there in the Dropbox, sir. They're asking about the role of mechanical power in cases of ARDS management.
That is the next best happen, because so as I said, the stress and strain, and then obviously, so very simple. If you are going to be stressed, is because the ventilator is giving you positive breaths. If I know, do it 10 times or 30 times. If I punch you 10 times or punch you 30 times, which is more harmful to you? Obviously, Muhammad Ali cannot take 30 punches, isn't it? They can only take 10 punches from him. So obviously, decreasing the power, that means decreasing the respiratory rate, decreasing the speed at which the punch comes into your face. Everything has to be decreased. That means the flow has to be decreased, the respiratory rate has to be decreased. And as I said, these are things which have to be done. But as of now, again, the same thing. If you have a mechanical power driven algorithm, wherein yes, now most of the ventilators, newer ventilators will have that software in, or you will have a on your phone, you can have the ability to do the mechanical power calculation. Even the long calculations can be done. There are modified simpler calculations also which can be done. But yes, the concept is that it is the stress, the tidal strain, and how frequently you are doing it, which is going to impart an energy into the lungs, and that energy is going to be deforming. And if that energy leads to a deformation from which your lungs cannot recover, that is ergotrauma. So yes, absolutely, the same stress and strain multiplied by the respiratory rate and multiplied the speed at which you give the tidal volume, that is flow rate, will incorporate a power, and that has to be part of the monitoring system. As of now, we are not able to calculate that on our ventilator, so you cannot press a button like a plateau pressure in a compliance so that the compliance is on the monitor. It'll be another 3-4 years before you'll get a ventilator where you can just press the power, and that will be also be there. So I don't think that, or we will have it easy to use software on your phone, which is also now already available.
So I think a lot of points are clear on the bedside. Those who are practicing the critical care of the putting on the ventilator for the patient.
Madhu, 1 minute. So thank you, Ramsubban sir. That was an excellent overview of both driving pressure and PEEP titration on this part. I'll just try to put some practical aspects of this. As you said, any patient with ARDS comes and we tube them, put them onto a ventilator, and we set as for the ARSNet protocol. And then the two things now came to all of our mind: targeted driving pressure as low as possible, and probably titrate the PEEP for an optimal level. But the point comes is when a very sick patient is on a ventilator, targeting both of them is a challenge. So when you target both of them, your minute ventilation drop down. You try to push your respiratory rate high. Then you think about a mechanical power going high. You don't know whether which is causing harm. And now you have a new formula saying rate versus your driving pressure, which is going to be more harmful, maybe 4 times of it and something like that.
Correct.
Now the question is, most of the times when we have this situation, we try to accept a permissive hypercapnia, don't target a normocapnic state, allow the CO2 to build up as long as you can allow 7.25, 7.3, whatever you target. And now we are talking about permissive hypoxemia also, don't target to be a normal voice. But sometimes it doesn't happen, so we prone them. So this is acceptable because it is available to all throughout, all of us can do it. Now post-proning, it's kind of a physiological recruitment. You turn the patient, you expect some amount of posterior segment get recruited there. So this is what the last limit for any regular standard ICU. Now on prone, on whatever physiological recruitment, you're not able to maintain a minute ventilation, not able to get a required oxygen indices or a carbon dioxide, the patient is deteriorating. And now you are not talking about just lung, other organs get affected because of hypoxemia and you deteriorate. So what happens? The targets go up, patient, the clinicians in the bedside try to target it because this is the point probably where we break down for a alternative methods. We need some help of extracorporeal membrane oxygenation or something, which is, if it is available, is the next option. But unfortunately, I still believe more than 80 to 90% of Indian intensive care centers cannot access it. If the centers can access, patients cannot afford it.
Correct.
So that's where we stop. So I still had that memories of your talk of debate. That's the reality. We may think many things that we should switch to ECMO at that time, but it's not happening. So now it comes that I do injure my lung and take a wheelie at hit, target oxygenation and see if some amount of lung gets injured, but my patient gets alive, versus no, I stick to my protective lung strategy and allow my patient's hypoxemia to go and till that point. So how do you take that call there?
So I think at this point in time, you realize that I should do no harm. So once you realize your faith that so I at this point in time is concentrating more on, do I have good source control? Is my sepsis control? Is my, can I limit the transfusions? Can I limit the fluid overload? I'm looking at all the other things more than the ventilator at that particular point in time. And at that particular time, I would say close the lung and forget about the lung. Hey, if you cannot afford ECMO or you don't have ECMO, there's no, as you rightly said, ECMO is not we have debated this also, and that's not the solution to it. We know ECMO works, but we don't know for whom, and we know at what cost it works. So it is probably not a solution for everybody. So at this point in time, it is to, I said, definitely. So what the slide that I always put is by the study by a case report in chest in 1984, where the patient survived with the SpO2 of PaO2 of 30 for many days. And this, as long as your lactic acidosis is not there, if you have got a decent map and you got only a lung as a problem, and you can maintain the other aspect of sepsis and all those things going on carefully, things won't harm. So again and again, the message is it's not the hypoxemia it's going to kill. And acidosis is generally good for the heart as compared to alkalosis. Acidosis, heart prefers acidosis anyway. And we know that we can accept a CO2 anywhere from 50 to 65 very easily. 65 for the brain and 50 for the heart. But I would take 60 as a PCO2. Sure, but once the PCO2 starts climbing beyond 60 and my pH starts falling beyond 7.15, and this is therefore despite prone ventilation, then to be honest with you, this is one situation where I'm sure ECMO is the only solution at that particular point if you want to be aggressive. And if not, if you don't have the resources, we just have to forget about it. We really cannot try. We cannot say that I'll take Willy and I'll do harmful ventilation, because then you are just prolonging the agony. You might save the day and you might have a saturation of 88% by the end of the evening, but 3 days later, another 3 lakh rupees down the drain also, he will not be there. So I think at that time, once you have done your maximum, you have to accept and say, this is the maximum that I can offer to this patient because of the resources and because of what they are. And we communicate that to the patient and saying that there is nothing more that we can offer right now. And we just have to give time. Sometimes people do well and they do well, as long as their tissue perfusion is okay.
And the take home message, if I understand clearly, sir, it's not oxygen indices, it's not just a carbon dioxide indices, but it is also the protective lung indices. You
Yeah.
don't cross your limits and harm the patient. Allow it, whatever it is. Sometimes if you take care of all other things well and the infection gets better, patient may recover. So only chasing those indices, hurting the lung, may not be a way forward at this point of time. That's what you're
It's never the way forward. And I think we have realized in the early 70s, what we ended up was people used to say, no, the disease has progressed.
I think
My boss always used to say, oh, ARDS has progressed. And we now, even in our unit, you will say ARDS has progressed, but it's probably progress because you're doing a large tidal volume just to you keep on ambu bagging with 2.5 liters to keep the saturation open. What are you helping? So eventually 12 hours later, the X-ray would be even worse.
So this is again giving a message. It's not just those dead ends, but sometimes I have seen things happening that in early trainees targeting a saturation of 94, 96 with those actually crossing those limits. It's fine. It's fair enough of 88 or 90 somewhere. If you are able to achieve that with a driving pressure of 15 or 14 and probably a tidal volume of 4 or 6 ml with a CO2 of somewhere around 60 if you have no neurological issues at that time. So all those who actually are listening to Dr. Suresh Ramsubban, he is very clear. It is not just indices of oxygen or carbon dioxide, but protective lung strategy. Do not cross those limits. If you're crossing, you're deliberately injuring and harming the patient. Outcomes will equally be harmful like your hypoxia and carbon dioxide. I think with this, I thank Dr. Ramsubban and Dr. Madhusudhan Jaju. Both of them has recently enlightened us on this. Dr. Madhu was also a part of the NAPCON with the same topic. And we had a very good attendance and audience for the almost an hour, more than 100. And we reach around 4,000-5,000 audience overviews in a day. And I thank Ramsubban sir in actually accepting in such a short notice. And Dr. Ram, again, another Ram was waiting for his talk, but because of floods, probably he requested me for the next time. And it has been a pleasure for us to listen to all of you, sir. Thank you for being a part of it. And I thank all the participants and we conclude the session. Thank you.
Thank you. Thanks a lot.
Thanks, everyone.
Thank you. Thank you, Venkat. Bye-bye. Good day.